Fantastic. Thanks so much, Sid. And it's a pleasure to be with you all this afternoon and to see so many of you from right across Canada. So I'll move fairly quickly. This is a big topic, so I will move quickly, but you have my slides. And here we go. So I don't have any significant conflicts at all in relation to this presentation. I do have some grants as listed there. And the only funding for this comes from the Public Health Agency of Canada, and we do our very best to be evidence-based where possible. So these are the learning objectives. So I'm hoping by the end of the session, you will be able to list some key precipitating factors for delirium and to be able to select some appropriate screening tools and be able to describe some strategies to prevent delirium, and then to be able to outline some management approaches. So what is delirium? It's really an acute disorder of cognition. It's brain failure, essentially. In many ways, it's poorly understood, but it is common, serious, costly, often under-recognized, and associated with high mortality rates. These are the actual DSM criteria for delirium. So it's a disturbance in attention and awareness. It develops over a short period. It represents a change from baseline and tends to fluctuate in severity during the course of a day. And then there has to be an additional disturbance in cognition. It could be memory, disorientation, language, visuospatial ability, or perception. So any one additional disturbance. And then it's not explained by some other condition. And there is evidence from the history, physical exam, or lab findings that the disturbance is a direct physiological consequence of another medical condition, substance intoxication or withdrawal, or exposure to a toxin or multiple etiologies. So we can talk about that later. This is from an excellent paper by Maldonado. And so these are some of the domains that are disturbed in delirium. So again, impairment of consciousness and attention, a disturbance of cognition, psychomotor disturbance, circadian rhythm, so that's the disturbance in the sleep-wake cycle, and then emotional dysregulation. So that's an additional one, really, but there are often emotional changes, as you see there. In the same paper, these are the different types of delirium that you may see. So generally either hypoactive or hyperactive. So hyperactive is the very agitated, delirious person. Hypoactive, the person is much quieter and withdrawn. And we often get a mix of the two. So these are some of the predisposing factors. So these are things that make it more likely that you could develop delirium. So increasing age and dementia and cognitive impairment for sure increase our risk, as well as changes in function, impairment or disability, sensory impairment, the vision or hearing, dehydration, malnutrition, a whole variety of medications, drugs, and then really any existing coexisting conditions. Whereas these are the precipitating factors. These are the things that will actually set off a delirium episode. Again, drugs are very, very important. A variety of different drugs can set off a delirium, so different psychotropic drugs, narcotics, anticholinergics that we'll mention later, but also withdrawal from some drugs, including alcohol and benzodiazepines. So infections, of course, are a likely cause of delirium. Post-operative, various physiological changes in the body, such as abnormal sodium, any organ failure, for example, respiratory failure with hypoxia. And then adding to this, environmental changes that could actually perhaps contribute to the development of a delirium, such as the environment within an intensive care unit or the use of restraints. And then there are other things like sleep deprivation, stress itself, and inadequate pain control. Very briefly, an 81-year-old retired school teacher in a general hospital, surgery for hip fracture, lives alone. Her husband died 2 years earlier, and then 2 days after surgery, she suddenly becomes agitated, disoriented. She has visual and tactile hallucinations, paranoid delusions, day-night reversals. She wants to leave the hospital. She's been given Haldol, put in restraints briefly. Not too much in the medical history: hypothyroidism, mild hypertension, urine incontinence. Current medications listed here. Occasionally uses her daughter's Zopiclone for sleep. She's restless, distractible, tremulous, has a sensation of bugs crawling on her skin, mini mental of 18, impaired clock, mildly elevated liver function test. So in the chat, could you please name one likely cause for her delirium? There's no correct answer here, just something that might, given this history, have contributed to the cause of her delirium. Terrific. These are great answers. Thank you. Yeah, super. Right. And you mentioned a whole variety of different possibilities. And that's where you have to become a detective sometimes trying to figure out what is the actual cause. So okay. And then, thank you. These are excellent. In talking to the family, it turns out that Mrs. A enjoys several large martinis every evening before dinner, and that she's been drinking alcohol more since the death of her husband 2 years ago, and is becoming a bit forgetful and has had a number of falls. So now in the chat, please name the most likely cause of her delirium. Yes, you've all got that. Thank you. Exactly. So it just shows getting the history can be critical in figuring out what's actually going on. Thank you, everybody. It's an image of Salvador Dali. It really describes how I think a person may feel or may see the world when they're delirious. And the epidemiology, so amongst older individuals, so out in the community, the prevalence is low. But as soon as you go into a hospital setting, the prevalence becomes quite high. And as you see there, post-operatively 10 to 15%. Hip fracture is a very common cause for delirium. Almost half the people, older people who have surgery for hip fracture, develop some degree of delirium. In long-term care, the numbers are lower, but if you actually follow people, say, over longer periods of time, from one study, 18% incidence over a year, and a long-term study in Ontario, 40% over almost 3 years. Very high rates in special populations such as palliative care or people with advanced cancer and intensive care. There is overlap between what we see with dementia, depression, delirium, the 3 Ds, of course. And it can be difficult sometimes to figure out what's actually going on, or 2 of these things happening all at once. That's not unusual. For example, it's not at all unusual to have a person with dementia who then develops a delirium on top of their existing dementia. And this chart highlights some of the key differences between delirium, dementia, and depression. So delirium really is an acute change. That's critical. So getting the history and realizing that this is a dramatic, acute change. Levels of alertness. So as described in the DSM criteria. So if someone's lethargic or hyper alert, fluctuating, that's critical. And that's different from dementia or depression. And then this real focus on inattention, person being distracted, having real difficulty with attention, is very common in delirium. And yeah, you may see that to some degree in dementia, but or in depression, but much less so. And again, the chart describes all of the different variations. Perception is interesting because hallucinations are very common in delirium, vivid, usually visual hallucinations. But of course, you can get those with various forms of dementia, particularly dementia with Lewy bodies, rare with depression. So what do we understand by what's actually going on, and why are there so many different causes of of delirium. These are some of the possibilities, again, from that paper by Maldonado. So actual aging, neuronal aging, and neuroinflammation, oxidative stress, neuroendocrine changes, circadian dysregulation, changes in neurotransmitters in the brain, and then actual disconnectivity between networks, neuronal networks within the brain. So there's a lot going wrong. And in terms of actual neurotransmitter changes, there are a lot of potential neurotransmitter changes that can contribute. The one we think of a lot is to do with acetylcholine, which is an important neurotransmitter for memory, and any kind of blockage of that neurotransmitter system. So that's the red there, cholinergic inhibition or anticholinergic activity. We know that's critical, but it's not by any means the only neurotransmitter change that we can see. This is anticholinergic effects that, so clinically the person becomes hot and dry and may have visual difficulties. They may be red and mad as a hatter is the delirium, in fact. Delirium's often under-recognized, even in general hospital setting where you would think everyone's on the lookout. It's often unrecognized by nurses and physicians. So any thoughts about why that could be the case? If you have any thoughts, if you could just put into the chat, that would be really helpful. Yes, good answers there. Right, no baseline. That's a real difficulty. Yeah. Exactly. We often don't know. Yeah, and confusion overlap with dementia. Exactly. And we don't know what's going on. We don't know what the causes are. Exactly. Yeah, a lot of people think it's dementia. Yeah, exactly. Right. Thank you. Thank you very much. So these are some answers and the fluctuating course. So, when the doctor comes in, the person's just fine after a night of being agitated all night. And I think these parallel a lot of the answers that you guys put in. That's great. Ageism as well, in fact. Aren't all old people confused? No, they're not. So there are guidelines. The CCSMH, Canadian Coalition for Seniors Mental Health, has guidelines that go back many years, and then they were updated 2014. So that's still a long time ago. There are separate guidelines on delirium at the end of life. You can get these and many other resources and documents from ccsmh.ca. Now I'm going to switch and give you some of the recommendations from these guidelines and from other recommendations. So for screening, the CAM is widely used, a confusion assessment method, which I'll describe in a minute. There is a separate or different screening tool for withdrawal, as listed here. It's SIWA. This is the CAM, very simple instrument. So, and it's a screening tool. It's simply to say, hey, you really should try and figure out what's going on with this person. They may have delirium. So there needs to be A and B, and then C or D. So an acute onset and fluctuating course, inattention. So they have to be there, and then either disorganized thinking or an altered level of consciousness. So it's a very useful screening tool, and there are variations of it. And this is another screening tool, assessment test that's gained in some popularity recently, the 4AT. And so it asks a number of questions, as you see listed here. So changes in alertness, so that's critical. And if it's clearly abnormal, you only need 4 points in this particular tool to suggest possible delirium. So that would be enough in itself. And then there are some specific questions to ask about age, date of birth, place, and current year. And again, if the points accumulate based on abnormal responses. Attentional difficulties actually tested with using months in reverse. And then again, the fourth criterion here is acute change or fluctuating course. And again, if that's present, that's enough to spark a further test or investigation. So why is it? One reason delirium is really important is that the outcomes are very negative. So for a lot of people, for many people, they recover completely and relatively quickly. But it's associated with increased length of stay in hospital, with increased mortality rates, increased institutionalization, and for some people, persistent cognitive impairment. And classically with delirium, it's reversible, but there may be persistent cognitive impairment, and that requires some explanation. This is a meta-analysis of 6 observational studies with follow-up times ranging from 6 months to 5 years. So people with delirium, compared to people who were matched but were not delirious. And remarkably and scarily, the people who had developed delirium were almost 12 times as likely to develop a new onset of dementia compared to the non-delirious patients. So certainly anyone who's had delirium should be monitored and followed because of this increased risk. This is an interesting paper here that looks at this whole issue of potentially persistent cognitive impairment. And what it basically says is that through a whole variety of mechanisms, the actual process of delirium may accelerate underlying brain pathology, such as Alzheimer's pathology, or through other mechanisms actually cause further brain injury, increasing the risk of dementia. So this is something very much for us to be aware of. I will just briefly mention delirium and COVID-19, and quite a lot's been written about this. Sadly, we had a lot of experience with people who became extremely ill, obviously, and ended up in intensive care with high mortality rates. And there's a whole variety of reasons why COVID-19 was a likely contributor to delirium, including direct invasion of the central nervous system by the virus. We know that happened for many people. Setting off inflammatory mediators, secondary effects of other organ system failure, and then on top of that, the use of sedatives, prolonged mechanical ventilation, people being immobilized, and the environmental factors. So all these things coming together contributed to high rates of delirium. And lots been written about this, including the management of delirium. Hopefully, we're not going to see much of that in the future. Let's hope. Just one poll question for you. You've been contributing actively in the chat, but this is a formal poll that we're going to put up. So how often can delirium be prevented? Would it be 90%, 65%, 50, 33, or 15? Thank you all for responding. That's terrific. Great. Okay, I'm going to end the poll and share the results. So let's see. So the highest vote went to 65%, and then followed by 90 and 50. You're a very optimistic group. That would be fantastic. Let's see if we could get rid of that now. Is it possible to get rid of that poll? I'm still seeing it on my screen. No, sorry.
We're not seeing it anymore.
So. You're not seeing, great. It was obscuring my
maybe you have a little delirium,
David. Yeah.
The visual hallucination.
Yeah. So the correct answer is actually about a third of the time, 33% of the time. And even that's a lot if you think about it. So, and there are a whole variety of programs designed to prevent delirium. This one's called the HELP program. It's been widely implemented. It came from the States, from Yale. And it included a whole variety of things, keeping the mind active and oriented, early mobilization, helping people sleep well without drugs, making sure people can see and hear, and staying hydrated and eating nutritious food. All of those things which were often implemented in various programs with the help of volunteers. That's a poster for the program. Sharon Inoue was the mastermind behind this, one of the gurus in this field. She actually studied this way back in 1999, published it in the New England Journal of Medicine. And what she and her colleagues found was that this intervention was able to reduce, in a randomized controlled trial, was able to reduce the incidence of new delirium from 15% down to 10%, which is pretty good. What else? Is there anything else that could prevent delirium? Maybe there's just a little bit of a signal around melatonin, which of course is good for circadian rhythm disturbance. So a little bit of a signal that maybe melatonin could be helpful, but it's not at the point where that's being used in clinical practice. In terms of how we look after people with delirium, so one of the most critical things is figuring out what's the underlying cause and then trying to treat that. So that involves, comprehensive physical exam, routine investigations that are listed here. Different physicians might choose a different set of investigations depending on the clinical picture, but these are commonly done. Looking for a whole variety of abnormalities, particularly infections, of course. Whole variety of non-pharmacological interventions that you see listed here. Again, supporting the person's physical health as much as possible. These are all really important. Helping the person to stay safe, and environmental strategies, so helping the person to become reoriented frequently, adequate lighting, the use of clocks and calendars and whiteboards and so on, and avoiding putting delirious patients in the same room together. That seems like a good recommendation, where possible, of course. Bringing family members in, again, where this is considered to be helpful. What about pharmacological management? So a lot of people with acute delirium are treated with psychotropic medications, but our guidelines and virtually all similar guides suggest that these medications should be reserved for those in significant distress due to agitation or psychotic symptoms, possibly in order to carry out essential investigations or treatment, and then to prevent the older person from endangering themselves or others. Generally, people who are hypoactive and quiet should not be treated with a psychotropic medication. There's no reason to give them medication, adding additional medication. So antipsychotics are the treatment of choice if one reaches the point of needing to use medication, and with one exception, and that is if there's a withdrawal state. So alcohol withdrawal, like the patient I mentioned earlier, or benzodiazepine withdrawal, then actually benzodiazepines are a better treatment than an antipsychotic. So again, we would use low dose, short term, very important, very low dose, the lowest dose possible. And antipsychotics that are considered helpful include the older drug haloperidol, or one of the newer atypical antipsychotics. If a person has underlying Parkinson's disease or Lewy body dementia or Parkinsonism, then quetiapine would be the favorite antipsychotic. If you're going to use Haldol, it should be very, very low dose to begin with. And baseline cardiograms are recommended where practical, where possible, because there are concerns about a prolongation of the QTC interval, which can be dangerous. So we have to be careful around that where possible. This diagram comes from a very recent publication in the Canadian Medical Association Journal by some Canadian colleagues. And they basically say in this situation, in choosing an antipsychotic, you really should think about the potential side effects and choose the one that's least likely in your individual patient to cause difficulty. So I think this is quite a useful chart. And as I mentioned, benzodiazepines would be used for withdrawal states, and it shouldn't be used in other situations. Been some interest in the use of cholinesterase inhibitors. These are the drugs that we use to actually treat dementia, Alzheimer's, and other dementias, such as donepezil. It looked like, given that some delirium is anticholinergic, that cholinergic treatment might be a really good idea. But so far, randomized controlled trials haven't really panned out, so they're not used in clinical practice. Finally, some resources. These are for the general public, older patients and families. On the left, these come from the Canadian Coalition for Seniors Mental Health. This one's available in several languages. Also an excellent document from Scotland on the right. So in summary, delirium represents acute brain failure. There are multiple precipitating factors to consider. The use of the screening tools is really important, and the CAM is certainly the one that's most widely used. I mentioned that new tool of 4AT. People with delirium have a significantly higher risk of developing dementia, so this should be borne in mind and as we follow people. There are preventative strategies that can reduce the incidence of delirium. Optimal treatment of underlying causes is critical. And then the management includes non-pharmacological environmental approaches that are vitally important. And then the use of psychotropic medication should be reserved for those in severe distress or in danger of harming themselves or others. Thanks very much, and look forward to hearing from you with any comments, questions, concerns, etc.
Wonderful, David, and an excellent summary of a complicated literature. So that's terrific. Appreciate it. I wonder if I could start, please, by asking Marnie. I was just curious. In the chat, Marnie had put something in around the 80s and how delirium used to be treated. I wonder if that might give us a little bit of context. So, Marnie, do you want to speak to that a little bit for us?
I worked on a orthopedic from 83 to about 87. So we were both mostly orthopedic clients, but we did have some like prostate clients also. So back in those days, we honestly thought that it was normal for elderly people to come in and get confused following surgery. So we would just add to the problem. We would bring them out, put them in a chair, restrain them at the nurse's desk, you know, lots of lights, lots of people. We would drug them or try and drug them. Yeah, we really didn't do a good job at all. It was terrible. And their saving grace was if they did get out of the hospital, because, you know, quite often they would go to a long-term care facility following. But if the saving grace was they would get out, I think, get away from us, you know, and get better.
Right.
If they're lucky, they escaped.
Exactly.
Yeah, I remember as a medical student and intern and resident writing orders for those restraints and things, and just thinking back now on the harm that we caused. But thank you for starting us off, because that gives us some really good context for what we thought we knew then and what we think we know now, and hopefully how much more we'll know in another 10 or 20 years. And someone will look back and think about the things we were doing now, perhaps, as also being a little bit silly.
Yeah. Hopefully I won't be in one of those chairs.
We'll try and keep you out. Jackie, you had a couple of questions around melatonin and quetiapine. I think, do you want to speak to those a bit?
Hi, sorry, can you hear me now?
Yes, thank you.
Okay. So just anecdotally, I had heard recently about melatonin possibly disrupting circadian rhythm if people are taking too much of it, or if they're taking too much of it too late. I don't know if there's any truth to that, but I had heard that that was potentially a concern. And then in regards to just the second choice of antipsychotics versus Haldol for delirium that you would want to treat. In our practice, I come from palliative care, and we tend to use a lot of olanzapine. I think just because we have more access to more routes. It's also tends, I think, to kick in a wee bit faster. But I just wondered why Seroquel was the second choice. Was it because of the QTC prolongation? Was it because of that, increased risk of sudden death? And then I also recently had a patient who had Parkinson's disease, and I noticed that he was taking quetiapine instead of olanzapine. And I just wondered if there was any difference in the dopaminergic effect there for those two medications.
Yeah, so maybe I wasn't clear. Quetiapine is not necessarily the second choice. It's not. In fact, there isn't a first choice. So that chart that I put up, I might try and find that again because it's a good chart. If I could, yeah, actually. You can see that now, right? Again.
Yes.
Yeah. So we're not saying that there's a first choice, and Haldol is generally not a drug that we like to use actually in older people. It's very popular because of its multiple routes of administration, and it's also used intravenously sometimes in some intensive care settings. So that can be an advantage, but by and large, we don't particularly like the use of Haldol, and certainly we'd only use it in very small doses. Risperidone is probably a good choice in general, as long as the person's not suffering from Parkinson's or Lewy body dementia. Quetiapine, though, is definitely the best choice if the person has Parkinson's or Lewy body dementia. In fact, although we'd prefer not to use an antipsychotic at all in someone unless absolutely necessary. So, but this chart is supposed to help you to choose the best one. And the other thing, one reason that olanzapine is not generally that well liked is because the red on the right, it does have anticholinergic activity more so than any of the others, and that could worsen delirium. So that's one reason why it's not considered to be a particularly great drug for delirium in general. But the whole point of that chart, though, is individual selection based on the sort of risks of side effects, and again highlighting the fact that we prefer not to use them unless we absolutely have to.
And David, how about your thoughts around melatonin?
Yeah, so melatonin, it's quite a widely used over-the-counter hormone, right? Naturally occurring substance that can be helpful for some people for sleep in relatively low dose. Usually start with 3 milligrams. A lot of people take it. Some people find it helpful. Many people don't. It's also used a lot for people traveling because it seems to help people adapt quickly to different time zones. Dosage, I think we're not entirely clear about, to be honest. Some people will use higher doses, like up to 10 milligrams at bedtime. We're not even sure about the optimal time for it to be taken. Some people say several hours before bedtime, others say just before. So the evidence is a bit mixed. I haven't heard much to suggest that it disrupts circadian rhythm or is bad for it, but who knows? But I think the main point here, though, is there's not enough evidence yet for it to be used to prevent delirium.
Does that help, Jackie? Yeah. Great. Thank you.
And
Kim, you had a question as well around the antipsychotics, and also interesting question about rapid changes in medications. I don't know if there's some context or background you can give us for that.
Was that, sorry, Sid, I'm missing that question. Is that?
It was C-Fact Kim Brown, just before Claire's comment in the chat at 3:27, give or take.
Can antipsychotics trigger delirium or quick changes in medication? So it's an interesting question. In theory, it could possibly trigger delirium, again, particularly olanzapine, because it does have quite a lot of anticholinergic activity. Don't think I've ever seen it, although could have missed it. So, but in theory, just a lot of different drugs could potentially precipitate delirium, but I think that's fairly unlikely.
I see Kim has put an additional comment there. Maybe doesn't have the ability to put a microphone on, but a person has been tried on numerous meds when trying to discover why big behavior change.
Yeah, so no doubt, when you start adding in a lot of new medications, you can increase the risk of delirium, absolutely. And a lot of medications actually have some anticholinergic activity, even conventional, a whole variety of conventional meds that you wouldn't actually think have anticholinergic activity. Antihistamines, for example, drugs like Gravol have quite a lot of anticholinergic activity and can actually contribute to precipitating delirium. So yes, especially when you're adding in a lot of new meds, definitely.
Hi, it's Kim. Can you hear me?
Hi, Kim. Yeah, thanks.
Hi, sorry, I didn't realize I had the mic ability. It's actually a personal thing. My dad actually got diagnosed with delirium this time last year. And I would be getting calls throughout the night of they were switching this medicine and switching this medication. And it just seemed like he basically had a manic episode out of the blue. And between everything, I guess, medications, they had to bring him down because he was possibly going to be harming himself or somebody else, which was totally out of character. But I think it almost feels like they knocked him down so fast that it was hard to bring him back. Like the amount of medication that he hadn't had before. And then all these antipsychotic meds were pumped into him very quickly. And when they discovered they weren't working, they pulled them out very quickly. So we had like this quick up and downs going. I mean, and they were doing what they needed to do, obviously. But, 12 months later, you're like, I wonder if this is what happened here. Because, there probably were some other underlying things. But the problem was he eventually went to the point that he walked in and he never did walk out, and he went nonverbal, lost his mobility very, very quickly. And the one thing that we had going against him is he's a 6'3" man, and none of the nurses were very big. So once he became immobile, he became too heavy, and he wasn't an overweight person, but he was a big person to handle. So the bed wasn't big enough. They didn't have the lifts, those types of things. So I think once he went down, we didn't get him back up. Yeah. And they tried to medicate it, and the melatonin, when you're saying melatonin and all that thing, I was like, oh yeah, we did all that, right? And they did their best. I'm not there's no blame or whatever, but it was just like, oh. And when they said delirium, it's like, okay, where did this come from? Because we had no lead into this, right? But anyway,
I'm so sorry to hear that story of your. That
was a personal interest, but I would get calls at 11 o'clock at night. We need to change your dad's medicine because he tried to bite somebody. And I was like, oh, okay, that's so. I mean, you don't say no to that. If a medical team says to you they need to change meds, they need to change meds, or they're, we need to restrain your dad. Okay, you're restraining my dad because you need to, but. I understood that, but it was just like, but things seem to be prescribed and taken away very quickly.
Yeah, I think there's no doubt, when someone is very agitated and delirious, whatever the underlying cause is, it's very, very hard for the staff. It's hard for the person themselves who are going through a horrible experience, but just trying to keep the person safe and comfortable, and often not pulling out all their leads and lines and everything. So the staff do their best, I think, to sedate the person, but sometimes they overshoot and might use excessive doses of medication. We certainly see that sometimes. Yeah, that can have bad effects, as you're suggesting. And
the geriatric principle, sort of start low, go slow, but get where you need to go. You have a 6'3" guy who's agitated, and that we tend not to do that, unfortunately, right? And there's a tendency then you get these oscillations back and forth. Yeah, thanks so much, Kim, for sharing that. That's a very moving and powerful personal story. We really appreciate that.
No problem.
I'm going to move on, if I may. Lauren is asking a question around best practices for community management. Well, that's a great question. Do you want to expand on that just a titch? And I think it's true that all of us who work in the community, it's always like That's what it was, right? In hindsight, as opposed to in foresight. Do you have some context, Lauren, for that comment or question?
Yeah, so I work as a registered nurse in the community who does home visits, primary care focus for patients. And often I get these cognitive referrals like change in cognition, family concerned, and that's all I get. Sorry, my dogs are wrestling in the background. I'm trying to get them to quiet down.
Okay. We love
so-
dogs.
Okay, so when I do some home visits, delirium's always on my mind, right? Like part of my role is to rule out, because I'd rather a change in cognition be anything but dementia, right? So I'm looking at hearing, I'm looking at sleep, I'm looking at nutrition, stress, mood, all of the above, right?
Yeah.
And so when I have a patient that clearly does present to me as what I think is fairly confused, even though I don't have a baseline, I always want to rule out a delirium. I'm like, hey, how's your, bladder habits going right now? But I really struggle with access, right? I'm a community health nurse. I'm in the community. I don't have the ability to dip a urine or even get a urine sample without the ring around of, I need to get you to your family doctor, to get you a requisition, to get you to the lab, and I'm seeing patients on a Friday afternoon. I don't know how to rule out delirium, right? And I really hit a brick wall time and time again.
Yeah. So, I mean, I think I would say, if you're pretty sure it's delirium and you have the history, this is an acute change and a dramatic change, and they really seem unwell, it's reasonable if the person's willing to get them to an emergency room for an assessment.
And I have, like, for sure, right? Usually I use urgent care over like the ED.
Yeah.
Right. I'm like,
That's good.
Can you get your family member? I'm also very fortunate that we are connected to a primary care clinic that does have like after hours, and I've finessed people in that way before, but sometimes I do find a barrier to, like, we know this, but then trying to, rule it out in a reasonable amount of time. And I'm in Alberta, so wait times to see family doctors sometimes can be a little bit longer right now. So the other challenge I have is people are like, oh, it's not a big deal. It's not a big deal, especially when it's like a hypoactive. And so they don't want to present to urgent care or the ED because they're like, well, they're just more tired. And I'm like, but, so I hear what you're saying. It sounds similar to you just try your best, right? There's no magic wand for that. It's just trying your best.
No, it sounds like you're doing a great job at being alert to the possibility, and that's the most critical thing, and and I think, getting the person investigated in that acute situation is really important.
Thank you. Yeah, it's an emergent. If it's an emergency, it deserves an emergency room or an urgent care center because it is an urgent problem. And the longer we delay before identifying that cause, the clock is ticking, then the more likely it is that some residual permanent effect will be there. Just mindful of the time, I think we're going to move on to our case fairly soon. But David, I just want you to make, if you can, one little comment. There are a couple of things in the chat around sort of natural history and post-operative delirium, and how long is it after that you could still possibly see improvement? And maybe you could talk about that a little bit for us, and then we'll move on to Kaylee and the case.
Yeah, well, of course, with older people, recovery of everything takes longer. So, younger people can bounce back really quickly. It's not unusual to see older people who've been in hospital, have had an acute episode of delirium, for it to take weeks or even a few months for a full recovery from an episode of delirium. And that seems surprising to people, but until recently I worked on one of our rehab units at the hospital, and we would see a lot of people being transferred from general hospital to rehab who are having residual delirium for a long period of time. And then, of course, there's that other comment I made that some people seem to never fully bounce back, and the family will say, well, they just haven't returned to their baseline, and they may be showing the first signs of an actual dementia.
Thanks, David. Still some great questions in the chat. I know we could probably talk all day. If folks have comments or answers to some of those questions, please feel free to put those in while we're continuing to chat, if you don't mind. Farah, do you have a poll that you wanted to show around the flex session? So as you know, in ECHO, we try and leave a couple of sessions that would be directed by your particular interests. So I'm going to ask briefly if you can take a peek at those and then click off the topic you'd like to see for the flex session on December the 11th, please, and thank you. I think you're only allowed one click because I click on all of them. Pick the one. Not sure if I'm allowed to vote, but I voted anyways. Vote early, vote often.